They are.
Okay.
Yeah.
All right.
Some coffee stains here and there.
Sure. Are they really?
Any like postcard love notes from days earlier?
Hopefully I can find some
The worst thing
money.
is when they highlight stuff all the way through the book. That's stuff. Anyway. Okay. So now we're going to talk about the physical exam and some of the things that you have to consider. I promise all of these principles and goals will kind of fall in place for you. I know you've probably not heard about this objective and physical exam in this way before, but we're going to talk about the intent of movement testing. We're going to use it in the case discussion, so you're going to pull this together with a case, and then we're going to go through the shoulder clearing exam. And we're going to use that kind of as a way to kind of jump off. It's something you'll use a lot with C-spine patients. So here are all your goals for the physical exam. They're pretty straightforward. Ideally, reproduce the patient's symptoms. And then find signs or impairments that are relevant to that complaint. And like I had mentioned, particularly with palpation, like vertebral palpation, you're looking usually for the signs, the changes in tissue texture, motion, that you would say, I know that joint is related to these symptoms even though I can't reproduce the pain by palpating here. And then when you understand the magnitude of the impairments, you should find also that that relates to the patient's disability. In that whole disability model, it really is a great way to kind of connect the dots. You're also going to look at associated factors. So what does that mean? You know, the easiest way to describe it is, I have a low back problem and I have a knee flexion contracture and my back hurts after I walk. That's a slam dunk. That's a physical factor that you know, unless I treat that knee or help the person get that knee straight again so that their terminal stance phase is back and normal, they're going to have a back problem forever as long as they keep walking. In the C-spine, you know, the upper thoracic spine, the high C-spine affects the low C-spine, the shoulder affects the C-spine, even your acromioclavicular and your sternoclavicular articulations can affect C-spine movement, as can chest wall. And then we need to come up with comparable signs. So comparable sign is a physical exam measure that you think you want to reassess after treatment. And so generally speaking, we come up with kind of short-term and maybe long-term things that you want to see change. So if I have a restricted shoulder motion, but I have a lot of pain to it, maybe you think if I treat the neck, I'm going to get Michael to the point where it just gets stiff there, and then getting the rest of his motion is going to be a long-term goal. Usually we want to have something that is a active movement, a passive movement. In the C-spine, maybe a neurodynamic assessment, and then some type of resisted test. Resisted tests aren't necessary in all C-spine problems, but that may be. And then you have intrasession reassessment. I treat Ryan's neck. I have him stand back up. We look at his neck rotation. We look at active shoulder flexion. We look at a few things. And then when he comes back, I'm going to reassess those to see if his prescribed exercise that I gave him has had a positive effect. If he actually did the exercise, which I need to make sure I know. Because intersession change can either be good or bad. You may be testing the outcome of your exercise prescription and saying, whoa, that was a mistake to give him that. Now I need to change that up. And then from all this, you're going to plan the first day's intervention. So your exam is going to be, as we just looked at, right, when we looked at the extent of your motion testing, is really dependent on all these things, including comorbidities. So if someone is horribly diabetic, as example, you're probably not gonna, and they have ridiculous symptoms, you're gonna be maybe a little wary of testing their neurodynamic capabilities, because day one, you don't know really much about the volatility of that patient. They've already got a compromised nerve. Is this gonna really add something to my critical thinking, decision-making tree? And do I now have a risk of actually making that person a lot worse? Their tissues aren't as good a quality. They have a lot of sugar rolling around their system. And then same with coexisting musculoskeletal impairments. So here's a principle that you have to put in perspective. So I was always taught, before you do any movement, you say, and how are your symptoms right now? Any resting symptoms? And it is the way I learned early on when I was in my orthopedic manual therapy training. We had an instructor that said, always establish resting symptoms, by the way. Well, they don't have resting symptoms. You know, their pain's intermittent. I don't care, you ask. And then I was being supervised by Margaret Anderson, who was kind of like the person who really I learned a lot from. And she said, "May I talk to you for a minute?" It was all this thing. "May I talk to you for just a minute?" She said, "We'll be right back. Just rest yourself. Stop asking about resting symptoms every 3 seconds." But I was told to. And that's what it can feel like if you are the bystander watching this and the patient. I'm like, wow, I didn't realize how. So if you don't have somebody that has resting symptoms, you've clarified that. Then you can just say, let me know what happens when you raise your arm overhead or turn your head to the right. How does it affect your symptoms? But don't say any symptoms down, any symptoms down, any symptoms down. It's not necessary. If they have horrible resting pain, you can ask once and say, what's it like right now? Okay, let me know if it gets worse as we're doing this testing. Please tell me when it increases or decreases your pain. Those are things you have to know. But persistently saying every time is not necessary.
But don't assume that they don't have any resting pain until you've made sure to clarify.
Yes. Yes. Okay, so you are going to be asking them for their responses during the physical exam. And then you make the decision. How often am I going to say any change in your symptoms? You could say, well, I need to know when this affects your resting, or your symptoms, brings on your symptoms. But sometimes they won't tell you. So you can ask just a couple of times, and then once you have established that they are credible in their ability to respond to you, then move on. And then, noting the relationship of other symptoms. So if you have multiple symptom areas, don't assume that the only thing that you are reproducing is the main thing that you're concerned about. You can say, well, okay, so that made your thoracic symptoms worse. What about the tingling in your hand? Any change there? No. Okay. And you keep using that methodology. So what do we do with the person who is highly severe, highly irritable? You, first of all, know that most of your time is going to be spent with patient education and coming up with a plan for mitigating their current situation. So in this case, you're probably going to say, I don't want to reproduce this person's symptoms repeatedly. Let's move to the point where we have an escalation in pain with 1 to 2 movements. So this is really that person who they don't look like they've slept in a couple of days, they're carrying their arm in, just horrible pain. So you're very careful. You don't over-examine them. And then the other thing is you're screening for cardinal signs. You all know what that means, cardinal signs. So in medicine, it's like you're looking for things that are,
It's like red flags.
well, it's kind of like red flags, but you're looking for things that are more pathognomonic, meaning, Do I think they have cancer? Do I think they're having an evolving MI? These are cardinal signs. You're doing a screening for that. What we're doing here, let's say this is somebody with radiculopathy, and you're screening for cardinal signs. The cardinal sign would be they have hyperreflexia, like, oh brother. They not only have a bad nerve root, but they also might be myelopathic, which means we need to move on and get them their imaging. We need to get them to a surgeon, that type of thing. So that would be cardinal signs. Or they have horrible motor weakness, and it's something that's evolving very quickly. And so we know if we get them imaging and we get them the right medication and maybe to a surgeon sooner than later, that can be reversed. Those are cardinal signs in our way. So that educational model, and you're going to get sick of seeing this slide, by the way, is here. This is where you're going to seal the deal on that trust and help that empower that person to help themselves. So on the flip side, this looks like Ryan Bear. I always used to think it looked like Ryan when he was little. Don't you think?
That's that commercial. That's a commercial, right? Did you get that?
Yeah, it was that
Yeah.
online
Stock
trading.
trading,
thing.
yeah.
Mhm. Yeah. Okay, so this is the person you love to examine because the sky's the limit, and so you're going to understand like how far you're willing to go, and if it's all the way over to combined movements, so be it, because you're trying to reproduce symptoms. So this might be that person that says, I get my scapular pain after swimming 10,000 liters. I swim every day, which is a long ways. That person's not going to be easy to reproduce symptoms on. So you may have to sustain, you may have to combine. So the components, you know this, but there's a lot of possibilities, and not all of these tests do you need to do on everybody. And that's the beauty of this kind of patient care philosophy. You do what you know you need to do to treat the patient. And it doesn't mean blindly moving on, but you're always going to do active and passive movement testing. You may do a functional test. And a functional test is something that they told you that they do that is unique to them. And so it may be, well, the only time I bring my pain on is when I reach up and back. And so you have them do that. You have them do that. Neurological function. Anytime with the C-spine that symptoms bleed below the acromion or they go into your scapula, then you're obligated to do myotomal testing and DTRs. And if they have dysthesias or paresthesias or certainly anesthesia, then you're going to do sensory testing. And we'll get there on Thursday. And then you're going to do screening tests. So the screening tests are, my hypothesis ranking is C-spine, shoulder, elbow. So you may decide I have to do something to look at the shoulder and the elbow briefly, sample things. Or maybe you think, I don't know if this is a neck problem or a shoulder problem, so you have to do what's called a clearing exam on the shoulder. You may think, I think neck 60%, shoulder 40%, so you do a clearing exam on one, and you do kind of a focused exam on the C-spine. And then, special tests. Special tests could be stability testing, shear testing in the C-spine. And then palpation. So you're going to, and I think I can't remember when it is, maybe it's next week, we go through palpation. Or maybe that's this Thursday. You're going to palpate everything from C2-3 for your standard C-spine exam, all the way down to T6. But if you do that on every patient, you're going to be running 3 hours late by the end of the day. So you have to make it targeted. So if it was a headache patient, we'd be palpating occipital lanal joint, the lanal axis joint, C2-3, and then maybe sampling a little bit of the lower cervical spine and then getting on to treatment. If you're dealing with primary lower cervical problem, you're probably going to focus anywhere from C4 down to C7, and then maybe sample a few things in the thoracic spine to verify if there's something you're treated on. You can't palpate every facet, every intervertebral joint, every costotransverse joint, except when you're practicing. that okay, Kelly?
Yeah, it is Thursday, by the way.
It is Thursday, okay, good, that's exciting. That's something to look forward to, for me at least. Okay, so you're gonna get after relevant joints, relative soft tissues, and in the area of the patient's concern. The worst thing we do is when we say, like, oh, yeah, my hip is really bothering me. It's a lumbar problem, I guarantee it. We palpate the lumbar spine, find things that are relevant, we treat it. Maybe the person doesn't totally better. They never looked at my hip. They never felt this area. So you go over there and you palpate around. So you give them some validation. That's the area that they were complaining about. So our exams can be one of two things. They can be very broad-based or they can be very focused. Most of our exams are pretty focused, and because of time and that we kind of want to get to treatment table. They also can be very vigorous or very gentle. And so this is dictated by our sins. The breadth, if you will, of the physical exam depends on how much involvement you think exists in other areas. So if it's, I say to you, I have neck pain right here, you're probably not going to go jumping into my T-spine or my shoulder because you're thinking, this is a facet problem. I'm going to get to this and treat it today and maybe clean this up and you won't have to come back. Versus somebody who has this, a lot of stuff going on here, radicular symptoms. Now you've got to look a little bit more expansive. And oh, by the way, I had an elbow fracture in 1979 and I can't straighten my elbow. Well, that affects shoulder function for sure, wrist function. So you may be looking at a lot of things, maybe not spending time there, but just kind of visiting sites along the way. So our intent, what's a relevant motion impairment? There's two different kinds. There's one that is, this is the symptom generator, it's a stiff joint, I'm going to treat it, they're going to feel better, versus this is a symptom generator, it is not very amenable to my hands right now, and I'm going to have to look at other areas, and so other relevant motion impairments might exist in other parts of the spine. You treat those, now you come back to what you know is generating it to see if it's now open to being treated. They're called compensatory impairments or secondary impairments. And then, when possible, you're hoping that movements will alter the symptoms. And again, this can be kind of disappointing. We see that not so much with active movements, with palpation in particular. And then we can differentiate between competing hypotheses this way. So here's what should be in your mind when you're looking at motion, and that is how far they move, what's the quality of movement. So if we look at someone's neck range of motion, and it looks fairly symmetrical, like if we put our hats on, if we were AFM docs, and I look to the left and I look to the right, it's like, yeah, it looks good to me. Well, maybe when I look to the left, I have no movement in my upper thoracic spine. There's no wrinkles going up to my lower C-spine right there. That's a quality assessment. You're saying the motions looks kind of face value the same, but in fact it's not. It's not well distributed. And how maybe that's relevant, maybe it's not. But you're looking at quantity, you're looking at quality, looking at through range movement, and of course end field. That's why we do overpressure. We overpress to elicit symptoms and to understand an end field, even though it's through multiple joints. And then whatever the limiting factor might be, out of this group here, it's usually pain or stiffness, but it also can be muscle guarding. So our body has an incredible way of organizing deep musculature to restrict movement, to protect. It's our body's way of protecting ourselves. It causes increase in muscle tone at rest, loads the joints, and then gives you a false sense of what the end really is. Instability You look at that and go, okay, no, instability is a limiting factor. If it's clinical instability, we're talking about something that radiographically you can see. But we throw that word around, instability, a lot in our profession. And so there is micro instability, which is a different world. It's this segment is dynamically not stable because it's not moving appropriately versus something that has like a spondylolisthesis. So if you had, let's say you have a degenerative disc in your C-spine that's so degenerative that there's a linear dissociation between the vertebral bodies. You can see it on a film. That's instability. But what it looks like is stiffness. The muscles have guarded so much that the joint actually feels very stiff. Okay? And you can treat that. You can treat, unless it's clinically unstable, where you think, oh my gosh, this person's going to have a cord lesion. But you can treat it to restore the motor control that it needs before you start doing motor control exercises. So these are our limiting factors. Primarily pain and stiffness is what we are up against. The spasm, the Australians call it hard spasm. Hard spasm represents itself as a joint being stiff, and you know it's hard spasm when you treat it, and all of a sudden, miraculously, after manipulating it or whatever, it now moves normally. Well, that wasn't a stiff joint at all. We thought it was. It was actually created by a very organized muscle guarding activity. Okay. So how we relate pain to movement. We want to know when they move, where do they feel it? And most of the time we're already familiar with their pain, but sometimes they'll have new symptoms because they've not tested themselves. So that's why it's important at least to clarify that. And then where in the range does it begin? Usually it's at their limit. It's either a painful limit or a stiff limit. But sometimes pain happens through range. Not as much in the vertebral column, but more in peripheral joints. And then does pain change as movement continues? So, oh yeah, I feel my pain, and then you overpress and actually feel a lot better. That's weird, but it can happen. And then how does the pain relate to stiffness and resistance? So this is something that you will come to appreciate and hate because you're going to learn how to draw movement diagrams. It's Kelly's favorite exercise. But it will only do it a couple times, but it's going to make you think about what you feel with your hands, or however you're assessing things, whether it's vertebral column or peripheral joints. Okay, so responding to emerging data. This is what happens to us with probably half of our patients. We make a disposition about the person's sins, and we say, I am not going beyond this based on what I know. And then you start examining them. This does not look like what I thought. So you kind of pivot from your original plan, not too drastically, but you see a different representation. Or it can go the opposite way. You think that you're going to be able to go for it, and the person is actually a lot more symptomatic than you gave them credit for. Or they have an atypical response. And you gotta say, why do they have this atypical response? Atypical response meaning out of proportion pain or symptoms that peripheralize that the patient didn't even tell you about. And you then have to figure it out on the go, or at least know what to do with that information. And then another thing is, no hypothesis that you came up with is supported. So the question you have to ask yourself, okay, have I done enough to really validate that my hypotheses are not part of the equation with this patient? That would be questioning yourself. Did I go hard enough? Did I do enough? Or do the features just not fit? And that's when the back of your spine starts to sweat a little bit because you're like, okay, I thought this was a musculoskeletal problem. I'm not finding enough here to make the case for that. And usually with these patients, you've come up with, you know, this might be my non-musculoskeletal hypothesis, but you really didn't think it was going to come to fruition. So we're going to be doing a shoulder clearing exam probably in about 45 minutes. And so just to give you an idea, we're going to go through clearing exams, you know, a week or two, I think, or 3 weeks. But a clearing exam is when you have a decision to make about a ranking and hypothesis. So we'll go back to what I had said earlier, C-spine and shoulder. Maybe it really is, I'm not sure which it is. And you decide, I'm going to do a clearing exam on one or the other, and then you're going to do a deeper dive on the other joint, okay? Because you think that's probably primary. So you commit to that. Sometimes things emerge there. So you do a shoulder clearing exam on me, and all of a sudden the shoulder clearing exam is, you know, all the things you're doing there actually reproduces my periscapular pain. Nothing. So a clearing exam is I have examined this joint to the degree that I feel very good about it not being the symptom generator. Versus a brief appraisal is, well, this is a neck problem. I want to see what the shoulder looks like in movement, so I'm going to look at active shoulder flexion, hand behind back, nothing fancy. I just want to see what the patient's willingness to move is. That's a brief appraisal. Or somebody who has multiple areas of pain, you get in there and you just visit the wrist, you visit the elbow to see if there's anything abnormal, but you don't think there's going to be anything there. You don't have a reason to do anything more than that. And sometimes it's a nice way to introduce your hands to a patient, particularly if they've never been to a physical therapist before. Before you grab their head and start moving them around, you grab their wrist, you grab their elbow, you gently made your way into the system. So there's 2 reasons for doing a brief appraisal. Okay, so before we get to our case, I want to just revisit that article that you read, okay? And to kind of put this out there, we're not asking you at this point to say, we want you to categorize this. Eventually we will, but it's a little more complex than this. But just so you kind of have this in your mind, what is the difference between nociceptive, neuropathic, and nociplastic, which are the broad terminology that now exists that was really, they came up with it in the International Association of the Study of Pain. And that group has done a ton of amazing work around pain. It's much more complex than just these categories. You look at this and, oh, these are the broad categories, everything else fits under it, which is actually true. But there are pain phenotypes that exist within categories. And I'm not, Steve Schmidt, who will be coming to talk to you about neurodynamics and chronic pain, will help you kind of slice these things up. It doesn't necessarily drive your treatment planning and clinical decision making, but it's really nice to know that maybe the reason I can't help this person is because they live in a phenotype that maybe is not amenable to what I have to offer. So nociceptive pain is an activation of nociceptors because of an injury to tissue, or it's kind of funny, it says threatened damage, which means there's a progression of compromise to an area peripherally somewhere. Whereas a neuropathic condition is kind of similar, but it's affecting the somatosensory system, meaning motor and sensory system at a nerve root or peripheral nerve level. And then the nociplastic category, which we always have called centralized pain, is an altered interpretation of tissue damage. So meaning there is nothing really that exists that would make you think this person should have these symptoms. And so it's this no clear evidence, but they have somatosensory symptoms, and maybe some bizarre symptoms along with it. For us, what this means is when we are trying to classify these, this helps us. I hate to say this, but 15 years ago, if it could help somebody, it would say, oh, they're centralized, which may or may not be true, which is a cop-out. I always thought it was a cop-out. Like, are you sure they're really centralized? Or maybe you just haven't done your due diligence, not to blame the practitioner. And then maybe they are. So this helps us a little bit in that nociceptive pain is proportionate. You as the healthcare provider would say, I expect this. This makes sense given their tissue damage, given their symptoms. They have intermittent sharp pain, dull aching or throbbing at rest in some cases. Rarely do they have dysthesias, burning, shooting, nocturnal symptoms, but they can. It's just less common. Whereas neuropathics, they usually are following a dermatomal or cutaneous distribution if it's a peripheral nerve injury. They have a history that supports a nerve injury. They may have nocturnal pain. In fact, most of the time they do. And then their symptoms are reproducible with many things. And they have positive neurodynamic tests. This is in the literature. Positive neurodynamic tests, what does that mean? Does that mean they reproduce symptoms or that it's limited or both? So the way a positive neurodynamic test is determined is any of those things. It's limited by pain, that's my symptoms, or it's limited, and I'm like, I have such a big stretch on my arm, stop, please. It's abnormally restricted. So the problem is neurodynamic tests are limited in the nociceptive category too, so it can be a little misleading. But the reason these are lumped the way they are is there's specificity and sensitivity around these test item clusters. And when Steve gets to this with you, he's going to give you this. You don't have to remember this stuff now, but it's like, I am 100% sure that given this test item cluster, it's nociceptive. And actually, as you move to the right and you get to nociplastic, which is disproportionate pain that might be very broad, meaning I don't just have localized pain, I have like pain all over the place. That's one of the characteristics. And then disproportionate ag and easing factors, meaning it, there's not a lot here, yet you say, I turn my head 2 inches to the right, even though they can go that far, and it sets their symptoms off. And they don't want to do it as a result. They have diffuse palpatory tenderness, which is kind of interesting because when I first graduated from PT school, there were these things called Waddell signs, and it was really related to low back pain at the time. And one of the things was diffuse palpatory tenderness. There were other things too, like to catch a malingerer, right? But the diffuse palpatory tenderness or supersensitivity. You have somebody who's young, healthy, lay on the table and you examine them and they're like they're pretty scared, kind of, you think, because of the way they're behaving, and then you put your hands on them like, like, wait a minute, I'm barely, and you keep putting your hands back and you realize, wait a minute, I can't touch this person. Why is that? I just touched your back when you were doing your shoulder elevation, how can I not be touching you now? It's a very real thing. And so this, when you start thinking disproportionate pain, disproportionate ag easing factors, diffuse tenderness, fear avoidance, they're catastrophizing, maybe they're depressed, they have negative emotions, all those things when you line them up are characteristics of something that's nociplastic. And so proven otherwise. Now maybe it's just somebody who's flim-flamming you, but I think those patients are very few and far between. Maybe if you had a practice and all your patients were either work comp or they were patients who had a whiplash-associated disorder and they were the ones who got rear-ended, maybe you'd have a higher proportion of people who were flim-flamming you. All it takes is like 1 out of 10 patients to do that and it ruins your day. It's like you distrust the world sometimes, right? I worked in workman's compensation when I first came here for 16 hours a week when I was doing this primary care pilot startup. And I used to get so pissed. And my wife, who works in work comps, it's like 2 people a week, Michael. Get over it. It's not that bad, but it would just get me. They're wasting everybody's time. They got, a free ride. I used to have all these things. But it would be easy to say, this is that type of individual. But now there's good evidence that this is actually a thing. And this type of person on a functional MRI has things that light up in their brain that none of us have light up in their brains. They actually have engramming in the central nervous system and the cortex that means that something different is going on for them. So, if you think about it from the standpoint of orthopedic manual physical therapy, nociceptive patients, we love to see these people. We don't have to worry about their nerves, we don't have to worry about anything but their musculoskeletal function and tissues and stiffness and all that. So they respond nicely to movement, they respond nicely to exercise. You'll see intrasession changes, you'll see intersession changes. And these people also say, yeah, I took Advil, 1 Advil 3 times a day, and I felt so much better. That's a good prognosticator. With our neuropathic patients, things like space for their nerve and vascularity, more importantly, is really important for these patients. And nerve gliding, things like that. They respond to orthopedic manual therapy, they respond to traction in the early stages, and then they're wonderful to treat with hands-on. You're going to see some intercession changes, intrasession changes later on as they get to that maturation phase of soft tissue healing, or even maybe the proliferation phase. They're going to really start to respond to your hands-on care. You're like, yes, I was so sick of doing traction on this person and taping them, and now I've moved them over in the soft tissue healing paradigm. They're helped by some meds in their early stages, or if they have a chronic radiculopathy where they had intraneural functional compromise, and they could have long-standing ramifications of that and chronic pain. So those are the people who are on gabapentin or Neurontin. In the early stages, they respond beautifully to non-steroidals. So if you do have that person with the horrible pain, they come in, steroids help. It's a game changer for some of these patients. As well as, that's why they make narcotics. And if you try to get a narcotic from a physician in Kaiser now, it's like, no, we can't do that. We'll put them on gabapentin. And it's kind of frustrating because the pendulum, just so you know, in the mid-90s, there was a class action lawsuit against 2 large medical systems, both hospital and medical group systems in Boston, for undertreating post-operative pain. And that opened the floodgates for Norco, for just about any Percocet and the myriad of narcotics that were out there. And the drug companies were making big bucks. And we always used to laugh. Friday afternoons, I need 30 Norco because I'm going to party this weekend. And I remember physicians just saying, Jesus, we have so many people coming in, yeah, I'm really hurting. And they're not, but you don't want to get in arguments. And so this is how the pendulum swung way too far the other way. And then people started dying, and now the pendulum, instead of swinging back to the middle, has gone back over to undertreated pain. And a lot of work has been done around comparing the efficacy of narcotics to like a combination of Tylenol and non-steroidals. And there's certainly in the post-operative world, there is some really good evidence that says narcotics aren't really that much better. But just imagine if you have unrelenting extremity pain because of a nerve compromise. That's a different world. And years ago I got really pissed. This is even before the paradigm swing, but there was an on-call doc in primary care, and he's like, I'm not prescribing narcotics. Like, you were my only hope for this patient. They are miserable, crying. Dude, It's not like it's a, not to say that girls cry, but girls cry maybe more than boys. And he was not a boy, he was like a dude you wouldn't expect to cry. And I said, just imagine if I took a baseball bat and I hit you in the shin right now. He's like, what are you saying? I said, and now imagine that the pain doesn't go away. That's what this guy feels. He goes, all right, let me come in and see him. And he ended up prescribing the medication. He just didn't want to do it because I think he was on the list of overprescribers. That's what I found out later. So there's a lot of stuff going on. But narcotics are an okay thing in this group. It's just a matter of finding a physician who's willing to do that. But they're all willing to do steroids, which they were not willing to do 10 years ago or 15 years ago, right, Kelly? I mean, there was like, whoa, steroids? Like you give it to somebody for asthma because they're going to die, or not die, but they're going to struggle, and you just give it out without any thought. But then you won't give it to somebody with RIDIC. And so that is now changed. It was like, oh, if you have steroids, you're going to end up with APM in your hip. And it's really not as prevalent as it was once thought, but there was some concern about that. So with our our nosoplastic group, they have central and peripheral sensitization, right? If you, their emotions can drive their symptoms, and if you just touch them, that might set them off. That's how sensitized they can get. It's very common for them to have latent evoked responses to anything, particularly what we do. And then, with us, it's like, oh, Stephen did this, and then I got this an hour later, it's Stephen's fault, versus this happens to me day in and day out with what I do or not do. Intersession change is rare. You don't get I treat them and like, oh, thank God, I feel so much better. Intersession change happens eventually. You'll see an improvement over time. They, in most cases, require orthopedic manual therapy procedures, but their response is unpredictable. So the thing that is tough here is that's not who we see in the clinic. It's not this, or this. It's a blend. So somebody with nosoplastic profile got there somehow. It was because of something that started it off. So they have underlying impairments from nociceptive or neuropathic conditions that have now blossomed into something else. And so the reality for us is we have nociceptive mechanical, but it started with nociceptive inflammatory. So if I sprain my ankle, I'm nociceptive inflammatory for a while. And then when we get to about 10 days and we start to do gentle movement on the ankle, that's now you're kind of entering the system with a combination of treating pain and resistance. And then now I'm at 6 weeks and you're cranking on my ankle. I'm mechanical. So nociceptive this needs to be both. The neurogenic or neuropathic category is one that usually has both components of nociceptive inflammatory and nociceptive, because the nerve doesn't get injured by itself unless it's traction. And then if we get to the point where we're at nosoplastic or central, then you now have a lot of things interacting here. And so how do we treat this person? When they get to where they're central dominant, it's not by doing hands-on care. In fact, if they present central dominant and then you treat them and like, oh, thank you so much, I feel so great, realize that you're going to get a phone call either that night or the next day. What did you do to me? Or I'm so miserable. Thank you for spending time with me, but I'm so miserable I'm not coming back. Because even though it looked that way, we decided to treat them over here, and they really needed a stepwise process to get there. You have to open the door to get back over here. There's also, I mean, affective is, of course, that person's emotion and psyche and so on. Viscerogenic can cause the same thing. Here's an area we'll talk about in months from now, with the autonomic side of the world. Autonomic symptoms have a very strange presentation. They can be the paresthesias that we kind of showed you with T4 syndrome. It can be, I feel like there's water running down my leg all the time. And they're not crazy. I feel like things crawling on my legs. I feel burning, I feel cold, I feel hot. So it's a myriad of things, and it's treated but in its own right, it's treated differently, but it also can interact with everything over here. So you pray for your autonomic patients to be just a T4 syndrome. It's so easy. That's mainly what we don't get, unfortunately. So that's the pain experience. That's what we see in the clinic. And so when you are seeing patients today and going forward, think about what is generating their symptoms and then what categories out of here they actually fall into. Because eventually we're going to ask you to make a stab at what category they're in. And I wish these things had existed when I was first out of training, because it would have helped me, along with the SINs, would have helped me be much more accurate in the treatment I was doing for my patients. Because we all flare people up. That's always going to be part of our, unless we don't do anything. If we're hands-off clinicians, that's easy. But when you put your hands on a patient, you're going to make people worse. And that's just because you're well-intentioned. So I told a patient on the phone a few years back, they were mad about somebody, I can't remember who it was. And I said, well, your therapist treated you. That what they did was not easy for them. They did it because they care about you. And sometimes well-intentioned interventions backfire on us. But it's rare, which isn't true, but it's more common than we probably think. But this could, knowing this can help you with that. Okay? Okay, so take a stand up, march in place. We're